you. Okay, thank you. So good afternoon, good evening, good morning, everyone, depending on when you're joining from. I'm joining you from Canada, so it's just 11:30, 11:23 here. So I want to welcome you to this very important session that we're holding today, and we have a guest joining us from Central Africa, right? Dr. Nyarko, you're joining us from Congo?
Yes.
Yes.
Yes, I'm in Congo, but now I came for a cervical cancer meeting. So I'm in Indonesia now,
Oh,
and the time is about 11, almost 30 minutes to midnight.
whoa, wow.
Yeah,
Well,
I'm
it's
in
very late for you.
but it's fine.
Well,
Yeah.
we're global. That's what we do. So thank you. So I'm going to introduce you very quickly. You are the team lead of the non-communicable disease department at the World Health Organization, and you are responsible for the African region, right? So today
Sure.
your presentation is going to focus on that sickle cell in the African region, and you will talk about the work
Yes.
that the World Health Organization is doing. And this is
Yes.
part of our mandate also has patient advocacy group, a global one, to engage with institutions like the World Health Organization to make sure that SCDC, sickle cell disease, is on top of all the files, because it's an important matter for our community. So we are happy to have you here today. Thanks for being here, and we are listening to you now.
Okay. Thank you very much. Um, I hope you can see my slides.
You have to reshare them, Dr. Kofi.
Okay, good. So I'm going to have a short presentation, then maybe we can have discussions after that. Strengthening sickle cell disease in Africa, what WHO is doing in the region. In the African region, we are responsible for about 47 countries. The northern part of Africa is also under WHO, but under the is part of Northern Africa and the Arab states. So we are responsible for 47 of the 54 countries. This will be the outline of the presentation. Brief on the burden, which you all know already, and we'll talk about the progress made, what are the challenges, what WHO is doing, and our priority actions going forward. We all know what sickle cell is because I've been following the presentations in the last 12 hours. And globally, this is the burden, but Africa represents about 75% of the global burden, 75 to 80%. However, we have a lot of people living with the sickle cell trait, about 43 million people living with the sickle cell trait. And when we look at Africa alone, the genetic trait prevalence is between 20 to 30, 35%.
Hey, Dr. Kofi.
Sorry.
Yes.
We're so sorry. We can't see your slides. Are you sharing?
Oh, yes. You can't see the slides?
No,
No,
we can't
sir.
see that.
So stop your share and then share again.
Okay, let me. Oh,
And
yes.
if you can't get it to work right, we have them on deck.
I sent it to your colleague, so maybe you can
We can
share.
share it for you if you want us to.
Yes, please do that. I think it's going to be faster, right? So that you can just tell us to move to the next slide.
Okay,
Yes.
he's pulling it up.
Oh, okay, good. All right.
Is it okay now?
Yes.
Go ahead and make it full screen and we should be good.
Is it okay now?
Yes, sir, it is. Perfect.
Excellent. So this is the outline. Talk about the burden, what the progress has been in Africa. We talk about what WHO has done and our priority actions going forward. So the burden of sickle cell globally, about 8 million people having the disease. And of this, about 70 to 80% are in the sub-Saharan African region. However, we have about a lot of people with the trait rather than the disease. And in Africa alone, the prevalence of people with the sickle cell trait, that is, they have the S, but it doesn't mean they have the disease, is around 20 to 30%. Some parts of Africa is more than 30. For example, in Nigeria, Democratic Republic of Congo, they have higher burden. But some parts of Africa, the burden is very low. prevalence of the disease actually is between 2 to 4%. So we are seeing a lot of people being born with sickle cell, despite all the noise that has been made, but still we have several challenges. So we will talk about that. When we look at the burden, 50 to 90% of children in Africa die of sickle cell disease. However, in the advanced economies, the mortality is not that high. And there is a study in France where in France they started looking at sickle cell comprehensively and using early infant newborn screening comprehensive care. And the mortality is less than 2%. But however, in Africa is over 50% because of poor infrastructure and a weak health system. We all know the impacts on families and patients, which we've talked about previously, so I'm not going to talk about that. So let's look at what has happened in Africa. Sickle cell newborn screening can be found in some of the countries I've listed, in Ghana, Nigeria, Senegal, Tanzania, Cameroon, Burkina Faso. But none of these countries have a full national newborn screening. They are just pockets of newborn screening, mainly due to projects or other studies being done. So there is no country in Africa where we have a full newborn screening. I know that in Jamaica, in the Caribbean, it's part of their national health system where they have newborn screening, but in Africa, it's not yet. We've been pushing. Some countries have started linking it over HIV newborn screening for children. And for example, in Burkina Faso and Uganda, trying to use that to screen children. There are some degree of integration with also maternal and child health, but these are all pockets of interventions happening, but not to full scale. And to support sickle cell, we're trying to have blood donations from time to time to ensure that this happens. And there is a good drug called hydroxyurea, which is preventing the pain episodes and complications. And very few countries are using it in Africa. However, there is a whole manufacturing plant for hydroxyurea in Nigeria. But current studies, because WHO are very much interested in making hydroxyurea accessible to everyone. But you know that hydroxyurea is a cytotoxic drug. So those in the earlier days in medical school, hydroxyurea was seen as cytotoxic, and doctors, especially in Africa, are afraid to prescribe. So the use of hydroxyurea is very limited and people don't prescribe, even though it is there. So the manufacturing plant or the company has reduced the numbers they are manufacturing because the demand is low. So I will talk about what you are doing to increase the demand so that those who need hydroxyurea will benefit from it. Let me talk about some of the challenges. In Africa, we all know the limited healthcare infrastructure. And the limited infrastructure, we're talking about not having the adequate manpower, the resources, and technology. Mention for primary health care approach for management of diseases, including sickle cell. But we realize that when cases are identified at the lower facilities, health centers, the capacity at the districts are not able to manage sickle cell. Sickle cell in Africa is managed in specialized facilities and specialized centers. So this has been a major challenge, and we need to train so that, and including new technology, devices, laboratory, and all this necessary for the treatment of and management of sickle cell. There is lack of awareness and understanding of the disease amongst the population and even among the healthcare workers in Africa. Access to care. We need comprehensive care. and that is also limited in Africa. And that has been a problem. Routine medical checks. There are so many people in Africa with the traits, but they are not aware. And even those who have the disease, as I said, over 50% die before the age of 5. So they are there with sickle cell, but they don't know, and they'll be having episodes and they end up dying without even knowing that they died of sickle cell. So that's the situation in Africa. Many African countries face challenges of newborn screening. As I've said, we don't have it in the system, limited research and data for decision making. And as I said, despite the manufacturing plants in Nigeria, there's limited access and also limited access to bone marrow transplant and gene therapy. So that is the situation in Africa, despite the fact that there are so many interventions and approaches to help. So let me talk about what WHO has been doing as the lead health agency globally, especially in the developing world. In the year 2011, there was a declaration called the Brazzaville Declaration by the World Health Assembly, which included sickle cell for the first time as part of non-communicable diseases of interest in Africa. When you look at the non-communicable disease of interest globally, from other regions, sickle cell is not a priority. But for Africa in 2011, we made it a priority because we have the highest burden. And before then, there was a regional committee meeting where we have a strategy, which I've given a shot on the right side, called the Sickle Cell Strategy for the African region, which outlines what should be done to ensure that all the key strategies and interventions are employed to reduce the burden of sickle cell in the region. But recent evaluation of this strategy has seen that we have not reached what we plan to do because of limited resources. Additionally, there were regional committee side events meeting, which was done in 2019 on sickle cell. There was a high-level consultation of partners in 2022. The recent UNGA, UN General Assembly meeting in New York in 2024, there was a side event on sickle cell. And last year's World Sickle Cell Day, in collaboration with the other global sickle cell coalitions, we had celebrated the World Sickle Cell Day to increase awareness. So these are things that we are doing in our region. And additionally, as I said, we did not have the needed and the required human resource. So we developed the PEN Plus strategy. That is an additional strategy to ensure that at the lower levels of care, we will have adequate human resource to manage sickle cell. So that's called the PEN Plus regional strategy, which was adopted in 2022. And now we have funding from a foundation of almost $10 million, which we are supporting 20 countries in Africa in training and building capacity for sickle cell. Additionally, we have developed what we call the WHO Sickle Package of Interventions. There are 6 modules to help in the management of sickle cell in the region. Because of limited human resource, we need to guide the nurses, those are the lower facilities, to be able to manage sickle cell. So the first module talks about, it's a standard guide for the establishment and for the operationalization of this integrated framework for the management of sickle cell. The next module is to reinforce the training of health personnel at the level of the health pyramid, looking at the lower level up to the highest level. It helps in understanding sickle cell disease to help prevent and effectively treat acute and chronic complications, and also ensure effective education. The third module is for comprehensive care, which talks about screening, health maintenance, how to ensure that people don't go into crisis, but they can maintain their health, management of complications, chronic complications. It talks about special considerations of pregnancy and childbirth, perioperative and surgical conditions, and psychosocial support. Module 4 talks about establishing centers of excellence for sickle cell at a higher level. And we have lifestyle, health promotion, and advocacy module to ensure that health promotion will be prioritized so that they can live well with sickle cell, advocacy and awareness. There could be genetic counseling. There should be lifestyle change that we can prevent sickle cell disease. And the last module has various appendices which helps the practitioner, vaccination, pain assessment and management tools. We have red cell exchange transfusion, management of hyperviscosity, hydroxyurea treatment, treatment of priapism, hereditary transmission diagrams so that they will understand. We have symptom tracking tools, simple blood transfusion, transfusion of sickle cell patient during pregnancy, hydration, drainage of corpus cavernosum, and leg ulcer management. So these documents were done with our counterparts in the US. We have a group from St. Jude and Harvard University. These were done by a group of experts both in Africa and abroad. And this is what is available now to support the region in sickle cell disease management. So these are what we are doing, and we having the resources has been the challenge, but national governments are supposed to prioritize sickle cell disease and get it done. For example, as I said, we need to have what we call early infant diagnosis. Now in Africa, there is a policy that every newborn, they take blood for HIV. We can use the same for sickle cell. However, there could be some challenges, but this is what we want governments to do. The point of care test is less than $1 now. Isaac Odami and Co have been able to negotiate that it's less than $1. So African countries have at least the money to do, but it's the prioritization. Once you know your status, then you'll be able to manage with simple penicillin V, folic acid, but we are not doing it. And it's because the population have not put pressure on their governments. So our priority action, we need to strengthen governance and leadership and prioritize sickle cell disease to be able to improve health outcomes and systems capacity so that they will train the people in our facilities to be able to manage sickle cell. People are not making noise. We need to make noise that sickle cell is there, it exists. People are dying before the age of 5 without even knowing that there is sickle cell. So if every newborn child or when you are going for immunization at the immunization centers, you have point of care tests and they know that they have sickle cell, we are going to reduce mortality drastically and people are going to live healthy quality life. And that is what we're looking out for. So we should establish national newborn screening to reduce mortality and improve quality of life. We should increase access to hydroxyurea to reduce morbidity and mortality. And luckily, as I said, we have hydroxyurea plant in Africa, but we need to sensitize clinicians so that those taking care of sickle cell patients will be able to prescribe, especially doctors in the lower level health centers. They have not been trained on management of sickle cell, so they will not even write hydroxyurea for you. And the patients have needless pain. So we need to train the doctors, sensitize clinicians so that they know what to do. They can demand for hydroxyurea, then it can be produced en masse to bring the price down and to ensure that it becomes part of the benefits package. And this is what happens in African health system. There are what we call the benefits package for various diseases, which is approved, and national governments give treatment for free. But unless you make the noise, nobody will do it for you. Let me give Ghana as an example. They started making noise for breast and cervical cancer. And with all these cytotoxic drugs, chemotherapy is very expensive. In Ghana, cervical and breast cancer is free under the National Health Insurance. But if you don't make noise, nothing will happen. So we need to create the demand. We need to get our governments accountable. WHO will provide the guidance, we will provide the documents, but we cannot go and make the noise. We have to involve the media, civil society organizations, so that what is due the people, because people don't know that sickle cell is an issue. They don't know. Still, there's no genetic counseling. People are still giving birth to sickle cell children without knowing. They think it's nothing because they don't understand the situation. So we need to increase awareness, improve on the knowledge so that appropriate actions can be taken. And as I said, in some parts of Africa, we have over 30% of the population having a sickle cell trait. So it means before you give birth to anyone, you need to know your status, else you can give birth to a sickle cell patient. If we do the right thing, very soon, the numbers will come down. And we need to push our governments. The governments, if you don't push them, they use the money for something else. So we should establish sustainable financing mechanism, and the money that is needed is not that much. For sickle cell, when you look at the numbers, the return on investment is very cost effective. But WHO, we have all the information. We need to engage the population, to civil society organizations, the NGOs, to make the noise so that our national governments will do the right thing, as was done in the Caribbean. I know Caribbean, they have the national newborn screening, and they have a health system which is managing them. So Africa too, we can do it. Africa has more resources than the Caribbean. So if Caribbeans have done it, Africa, we should do it. So thank you very much. And I'm ready for any questions.
Thank you.
Wow.
Uh,
I did have a question. I will check the chat. In your slide, so Dr. I remember at SCDAA, Dr. Isaac spoke about some of the challenges of implementing newborn screening, and so you can let me know your thoughts. He stated that, which I thought was amazing, that one of the difficulties is that women giving birth only stay in the hospital for 2 hours. So then they go. So this is it's impossible to be able to have newborn screening if they're not in the hospital long enough. Whereas at least in the States, they're in the hospital for over a day. And so newborn screening, of course, has been in 2006 universal, but it started back in 1973 in New York. So that's one of the issues he mentioned. The women are not in the hospital long enough for that to occur. So I think what he said was they do the screening when they come back for their immunization.
Organizations, yeah.
Okay. So
So let me, yeah,
yeah.
let me put some clarity on that. Yes, what he said is true, but it's in two ways. Screening can be done using the method, the gold standard, which is not the point of care. So if it's not a point of care, you don't get the results there and then. And therefore, even if you get the blood, like what they do for the HIV blood, they take it the moment the woman delivers in the labor ward, they take the blood and they do the PCR and they will give you your results. Not the same day. But for the sickle cell, if you do it and the woman leaves the next day, you may not have the results using the gold standard test, and therefore follow-up becomes an issue. But the point of care test, you can get the results there and then. However, you need to be with the mother and the child at the same time and give them the results before they leave. The point of care test, you give them the results before they leave. So if you want to do the newborn screening, it's not appropriate using a point of care test. But if you want to do early infant diagnosis, when they come back for immunization, at that time, the woman is okay with the baby. You can counsel them, you can explain things to them. So whilst they are coming for the vaccination, you can do the test, and within 10 to 15 minutes, you can have your results, do the counseling, and they can be linked to treatment straight away. So that is, so it's based on the infrastructure. That is why in Africa we talk about newborn screening and early infant diagnosis. We need to combine the two. Yes.
Yeah. So thank you for this presentation, Dr. Kofi. But I think it's a comment, and at the same time, I'm going to put a question for you.
Yeah.
So we are patient advocacy group, and all over the world, the sickle cell community is known as one of the community that has the most, like the largest numbers of advocates, because we are an underserved community. We have so many unmet needs, right? We don't have many treatment options. And you said it several times during your presentation that people are even sometimes dying before even knowing that they have sickle cell in some region of Africa. I'm African myself, and I visit Africa often, even though I live in North America now. And I noticed something in a very short time. Let's say I spend 2 or 3 weeks in West Africa. Within those 3 weeks, I will hear about sickle cell warriors passing, versus when I'm in here in Canada, where I live, you know? So I understand that the disease burden is huge on Africans specifically. So now, listening to your presentation, as a leader of a global alliance of sickle cell organization, I'm worried, because for us, we've been trying to be at the table with the World Health Organization with the hope that you will tell us that we will lead the way to have countries implement newborn screening, either when the child is born or at the first contact with any healthcare facility. We will promote research, because you didn't talk about treatment options, and we need to hear that. Hydroxyurea needs to be like the hydroxyurea file needs to be treated the same way the malaria treatment was, in Africa. That's the only solution, because the reason why people don't even, the doctors don't sometimes prescribe it is because sometimes I've been sitting in rooms where parents will say, I can't afford it. So don't even write the prescription, I can't afford it, because they have to take it for the rest of their lives, and it's expensive, right? So, and then also policy change. If we are raising our voices, so we count on the World Health Organization to amplify our voices and to say, we're going to sit together with the community and us and bring the healthcare providers and make sure that we get not only newborn screening, but also that we put in place policies that will protect this community. So I wonder who is supposed to make the noise that you're talking about. So we've been making the noise, and we thought that today you will tell us, okay, we heard you, and this is what we're going to do. So I'm worried, and maybe I didn't catch it during your presentation, please.
Okay, so just before this, I'm sure some of the people here also joined the WHO World Sickle Cell-A-Thon webinar. What we did in the Africa region is we tried to engage the African media houses on sickle cell for them to know the burden, so that in the next 2 weeks, they will hit the airwaves on sickle cell in Africa to push national governments to do what they are supposed to do.
Okay.
What we do, we have developed strategies. We have pushed the Ministry of Health to develop the sickle cell strategies and policies to say all the good things in the document, because it has to be in the document first. We have pushed for Ministry of Health to appoint. Previously, there was no even an officer at the national level responsible for sickle cell disease. Now we have pushed to have all of that in place. Now we need to push to have a budget line for sickle cell.
Yeah.
so that there will be budget line to talk about sickle cell to do what needs to be done. Once that budget line is done, we now have national strategy for implementation of sickle cell in each country. Then with those strategies, they will be able to do what needs to be done. It is through this push that some countries have started early infant diagnosis. Hydroxyurea has pushed to some countries, but still, from my presentation, realize that the coverage is still not where we want to be. And because we want, for example, newborn screening. When the mother gives birth, newborn screening in the country is free of charge. So when they give birth and you say, pay money for me to screen you, the mother will not do it. So for the government to do it, they have to see how much money is it to do their balance sheets and do, because always governments don't want to put money in. But when they start getting pressure from the civil society, they approve. When they do it, they approve. So, for example, if we make a lot of noise and they see that hydroxyurea, because Isaac Odame and colleagues went to Nigeria where we have the hydroxyurea plant, and they are ready to bring the price as low as anything, but they are saying the little they are producing, people are not even buying it because there is no demand. So once we all come together and are ready to use it, it will be manufactured in volumes so that the price will come down. So from our point, we are doing our best, but we want to also hear from the civil society. Let's take all the cases that you are aware of. Let's look at HIV. Governments and ministries do their best, but a lot of civil society made noise and it became free. And I told you, even cervical and breast cancer, which they are treating some patients for over $1,000 per patient. Because the pressure was mounting, they have approved. Parliament of Ghana approved, and it's not only Ghana. Some countries in Africa have started giving free care for women cancers. Moment it starts, what happens? Currently, I told you I'm in Bali for cervical cancer meeting. Because this has happened, now the international community is giving money for women cancers, breast and cervical and childhood cancer. They are giving money. We just finished the meeting this afternoon. They've made huge pledges in millions, and they are dedicating this money to countries in Africa. So, as I said, we've done a lot with these side events, and we have to continue the advocacy from the civil society. Whilst we do the guidelines, we do the treatment guides, research, we do the things from our side. So we should all do it together. Yes.
Okay, thank you. But I would like to make one comment, Dr. Rowley. Excuse me. So, we had a discussion with Professor Odami in Geneva recently. I met with him. So we talk about, people not buying or not taking the hydroxyurea. We are part of the community. And what I told them in Geneva was that the way it is presented to the community, and when I say the community, might it be in Africa or in the Middle East, we have culture. Culture plays a big role in the way we approach healthcare. Culture, religion, everything. Our values are different depending on the region where you live in. So I said in some part of the world, we have to look at that aspect also. And some education has to be done, right? When people are looking at reproductive health, the effect of hydroxyurea on the reproductive health, that could be a barrier for them to take it. And they were like, well, you shouldn't say that. I'm like, we shouldn't avoid the conversation. We should have the conversation and educate people so that they know that the risks are limited, right? Exactly. So I think some work needs to be done with us at the table. I'm bringing this to say that the patient voice, the patient advocacy groups, we know the community, we know what are the issues, we know what are the most urgent needs. We have to be part of any conversation that is happening. And most of the time, we see those meetings on TV or on the internet after they happen, but we're not there. So I want to
I think lastly, we will not just do it during 19th June. We can work together collaboratively, and if we have time every quarter or every month, let's talk about sickle cell. Once we
Yes.
start bombarding them with sickle cell, we will see a very big change. Thank you.
I hope so.
I like hearing that. So I heard you say several times, and I think it's global when you say that there has to be a voice. So with other groups, there's let me just say this first, and then I have the question. There's pain involved. There's resources that are involved, um, versus other groups that may not be triggered. So sometimes pain can immobilize you. It can be the barrier. Other things can be a barrier. I say that to say, you said that they have to make noise. My question is, do they know where to go to make the noise? In other words, is someone rallying? Is there a leader that says we're going to be meeting X, Y, and Z? Let's all make noise. I think sometimes you have to know where to go to make it. And is it known? Um, because I believe that people will gather together, but do they know where they need to gather together? Is there someone guiding them to get together?
Okay. Before he answers, I would like to add something to that.
Okay.
When I was speaking in Geneva, somebody said to me, well, Biba, you can speak, you can talk, as loud as you want because you live in North America. Because making noise in some countries is not something that is available to them, right? So we understand that. And that's when maybe us being here, having the freedom of speech, should raise our voices more, louder, and then make sure we support. And that's why the Global Alliance was created, that we have to come together, exchange knowledge, experiences, and then when they can talk for themselves, then we can be advocate for them. So that's what I'm going to add, and I will let Dr. Kofi respond to your question.
Thank you.
Yes, your response is excellent. The other thing is that from my experience in the area of non-communicable disease, all countries in Africa have what we call the Coalition of NGOs on Health. And in Ghana, for example, where I worked for some time before moving international, we have NGOs on, say, cervical cancer, NGOs on cancer, NGOs on malaria. So I think what is lacking in the area of sickle cell is to have coalition on health focusing on sickle cell or NGOs focusing on sickle cell so that these can come together to make the needed noise. As I talked about women cancers, we have a group of NGOs and civil society focused on women cancers. And if you go to Ghana, it's a number. So all of these started making noise, going to meet Parliamentary Select Committee on Health, doing all those stuff then. So I think there's more that we need to do to have a movement, and so that we can get there. Yes, especially in Africa. Thank you.
Thank you. Thank you for saying that. That's so true. And then we've started that movement. Gasto is here. We have a global alliance. We're inviting everybody to be at the table, regardless of your geographical position. But what we want now, we want you to be with us, to stay, because you promised that you will continue this conversation with us. We're going to set up meetings, and we will continue to talk to you to make sure that our voices are heard when it matters and when it's important, so that when you go into those meetings with countries, you can tell them, I heard from people of your region, and this is what is the most present issue for them.
And one more thing. So let's not forget about the US. I think everyone keeps thinking that we're so advanced. And so yes, we have we have the drugs and we have the technology, but I need for people to understand there's still a fight. And the fight is that we're constantly advocating for warriors just to get pain medication.
Yes.
They're not getting pain medication. It is available, but they're not getting it. They're not getting what they need. They're cutting them off early. And so warriors are suffering. I just yesterday spoke to a CHW that shared with me that there's a doctor that laughs at warriors when they are in crises.
Wow.
That laughs. So let's not forget about us, please, because we're here and we're still having to fight for warriors to be believed that their pain is real. Let's not forget about us. And so with that, this needs to continue. Oh my goodness, I wish we had more time.
Yes. We know it's late in Indonesia. You have to go to bed, Dr. Kofi.
Yes.
Yeah.
Thank you so much. But he
Okay,
said
thank
that
you.
we're going to have maybe quarterly meetings with them, with the team,
Yes,
and
it's
we
agreed.
continue this conversation. And,
And
I'm
and
going to send an email.
I also hope that you also have country presence in Africa, in various countries. We support various countries to also have a movement, not only at the global level, so that we will have a greater momentum to move forward.
Absolutely, absolutely. Earlier, we heard from Niger, we heard from Uganda. Today, they were here, they presented. So, yes, we do work with African countries, and we're going to hear from Tanzania, we're going to hear from Kenya later. So, yes, we do, and it's important, right? I think African countries have so much work to do, and they need maybe the more support than any other country. So we work with them, and we intend to do that, and we intend to bring everybody at the table, but we want you to stay also at the table with us.
Thank you.
Thank you.
Thank
Thank you very much.
This is just the beginning.